Okay, great. Well, it's my pleasure to introduce our moderator tonight, Dr. George Mandelaris. George has been an early adopter of surgical navigation right from the very beginning. He's one of our beta testers, provides valuable clinical feedback to us. He's also one of our master clinical trainers and a DSM member. Dr. Mandelaris attended the University of Michigan. He completed a 3-year postgraduate residency program in periodontics at the University of Louisville, where he also obtained a Master of Science degree in oral biology. Dr. Mandelaris is a diplomate of the American Board of Periodontology and has served as an examiner for Part 2 of the American Board of Periodontology certification process. He has served as an assistant clinical professor in the Department of Oral and Maxillofacial Surgery at Louisiana State University, and currently is an adjunct clinical assistant professor in the Department of Graduate Periodontics at the University of Illinois, as well as the University of Michigan. Dr. Mandelaris is a fellow in both the American and International College of Dentists. He is published in many peer-reviewed journals. Dr. Mandelaris lectures internationally on topics such as SFOT, surgical navigation, periodontology, and implant dentistry. George maintains private practices in Oak Brook Terrace, Park Ridge, and Lincoln Park, Illinois. George, the screen is all yours. Thank you.
Can you hear me okay? Okay, fantastic. Well, I'm really excited to take part in today's webinar. As Beth said, I was a pretty early adopter with my former partner, Alan Rosenfeld, for the last 20 years in CT technology and use of guided technology. And, I've always felt that, kind of what's next here. And I feel very strongly that navigation is, really the next big thing. It's the next leap forward in computer-guided implantology. So, I think to have real-time verification and validation of positional accuracy is where the profession needs to go next. And we're all here tonight really as early adopters to see two experts really take things to the next level. My experience so far has been fantastic, but it's pretty much been in single tooth, multiple tooth situations, partial edentalism. And I'm very excited to see what Drs. Kuo and Chiu have to show us today with their innovative thoughts and experience with managing transitioning a terminal dentition to fully immediate loading cases. So let me introduce the two speakers tonight, and we'll get this party started. I'll first start with Dr. Chiu. She received her Doctor of Dental Surgery degree from the National Taiwan University in Taipei, and then subsequently a Master of Science in Periodontics from Columbia University in New York. She became a diplomat of the American Board of Periodontology in 2016, as well as she's also a diplomat in the Academy of Dental Implantology in Taiwan, which she achieved that status in 2017. She's published in several peer-reviewed journals. She's a clinical assistant professor in the Taipei Medical University in Taiwan. She serves as a postdoctoral periodontal clinical instructor in the National Taiwan University and practices in multiple clinics throughout Taipei as a periodontist as well as an implantologist. In addition, she lectures in periodontics and implant dentistry both nationally and internationally. So we're excited to hear from Dr. Chiu. And her partner in crime tonight is going to be Dr. Kuo, who is a fantastic prosthodontist who received her Doctor of Dental Surgery degree from the Kaohsiung Medical University, the College of Dental Medicine in Taiwan, where she also completed her education, as I mentioned, in postgraduate prosthodontics, as well as achieving a Master of Science degree. She continued a one-year training in advanced education in prosthodontics for international dentists at New York University, followed by an additional year of clinical fellowship at NYU. In 2016, she obtained her diploma and Master of Science degree from Columbia University College of Dental Medicine and Prosthodontics. She's a former clinical assistant professor both at NYU College of Dentistry and Prosthodontics, as well as Columbia University. She holds various dental continuing education courses and gives many presentations nationally and internationally, focusing not just on prosthodontics, but also on digital implant dentistry and the digital workflow. She currently serves as a clinical assistant professor at the Taipei Medical University School of Dentistry, Prosthodontics Department. So we've got really two experts to present their work to us tonight and hopefully inspire us all to take things to the next level. So with that, I'm excited to present to you Dr. Chiu and Dr. Kuo. I look forward to an exciting hour.
Thank you, Dr. Ford. You guys can hear me, right? Thank you, Doctor,
Yeah.
for introducing. That's a very kind introduction. And good morning and good evening to all the friends from worldwide. It was great to see you guys. I saw you guys in chat room. And it's an honor to be able to share clinical experience and have some fun in dentistry today. So I would like to get started. So before I start the topic today, I would like to acknowledge our mentor, Dr. Dennis Tarnow, and his interdisciplinary team, who not only exposed us under solid dental education, but what's more important, it is the passion and dedication towards the dentistry that inspire all of us as students around the world, keeping us moving forward, getting better, and getting really fun in dentistry. We truly appreciate that, both me and Dr. Chiu. So Mr. Kuo, he walked into our clinic, requires various of dental treatment. So in modern dentistry, I guess most of us agree that it is important that we treat patients not only meet the functions, but as well as the aesthetics. So we look at the patient, we look at how his profile, how he looks like, and everything that we can appreciate it as. Wouldn't it be possible and wouldn't it be great that we could see through his skin and then we can know what's the correlationship along with the profile with the underneath dental problem? Wouldn't it be even better that you can actually visualize the underneath three-dimensional bony structure? So nowadays, as everybody must know, you have some idea about what the digital equipment and software can be utilized. However, as you can see right now over here, the information seems to be piece by piece and too segmented and don't have a structural way to really help everybody to get started. And for that, that's the purpose of today, sharing all this knowledge and have the workflow that we'd like to introduce to you guys. So how should we really get started the next step in digital dental world? Having a structural sequence helping us sorting out all the information and making validated to our complicated treatment. Before we talked about the digital dental workflow, I'd like to start with the workflow that's most relatable with your daily practice, which is the conventional workflow. So in the past, when we analyze the complicated cases, the data that you would need to collect would be addressing, of course, the clinical appreciations, and then you take photos, take some impressions, and the physical records. So all of those records that relying heavily on your eyes to observe this, and of course our fundamental knowledge to put everything all together. But also it requires the low tons of the imagination to really transfer everything onto the cast, and we can complete this, we call the analog phase, the diagnostic wax step, which will become the foundation of the future treatment plan. So the workflow that I break it down for you to get more clear is we always started from the data acquisition, regardless. That's impression, that's a record from any physiological or substantial record. And then we transfer that into the machine to try to analyze it according to the need of our treatment. And of course, at the last, we have the conventional way according to different materials that we can manufacturing through the procedures. As far as the digital workflow that we carry on, let's see how the digital equipment and the software could be substitute and assist the workflow for nowadays. With the same idea that we need to address the clinical appreciation, we now could be able to actually capture all the information through the scanners in the real three-dimensional manner as well as the color. And then we have the software nowadays to actually assist us not to utilize our, a whole bundle of the imagination, but we can actually visualize how we are going to plan our future teeth, our future plan. So with that, we can transfer the information and then utilize the software to plan the virtual diagnostic wax-up, which is similar as the analog base. So the digital workflow, the breakdown for you guys that you can take a look, similar as the conventional workflow, but we just substituting all the digital equipment, utilizing and applying it on the digital workflow. And then we transfer all the information also to start to planning it on, having the software to assist. And then we have the last piece, that's the computer aid manufacturing, that we have the digital software to help to be able to work it out and then to have materials applying on our procedures. So with that in mind, here would like to introduce the full digital workflow for full arch implant prosthesis that today we feature in utilizing the dynamic surgical approach to accomplish the full arch immediate loading protocols. So this is going to be the digital workflow that today we're going to walk you through and we're going to introduce you guys. So this workflow, our team has worked on it for the past 2 years, and there are a couple key factors that's crucial for the success and the precision of the workflow. Number one, you always need to properly determine the ideal teeth position. And number two is with that ideal teeth position, you need to integrate it among all the different interface that later on we will introduce, because you need to transfer all this information between different softwares. And the last piece of the puzzle is that you need to accurately superimpose all different type of digital images among the softwares. So those are very crucial for maintaining the precision and accuracy of your treatment. So let's start from the very first one, the scan. So you will have the scanner, you scan your intraoral condition. And then you have the software to assist you to have the virtual diagnostic wax-up. And that is, of course, transferring from the clinical, substantial, or physiological findings. Then you will have this design of the wax-up transfer into the format of STL file that you you exported it again for the dynamic navigation machine Navident, the software that will superimpose this virtual diagnostic wax-up along with the DICOM combing CT file for the planning of the ideal implant position, numbers, and the angulation depth, and so on. And then you can work around with your surgical procedures. After that, once you have all the implant that's been planned out, you will again export out the STL file from the Navident software and transfer that into the, you can see the bottom one, into here I use the 3Shape dental design software that you superimpose your pre-virtual diagnostic wax-up along with this Navident planned implant position, so that you can now determine where the screw access hole that in the future you need to relieve and spare for the immediate loading protocol. So the first bar that you will see from the top row, that's once you plan it out, you use the Navident, which Dr. Chiu will introduce later on, that you will executing the surgical procedure along the planned Navident, along the planned treatment, and then you just following through all the sequence one by one. The bottom row, you will see how we utilize the file that's designed from 3Shape software. We relieve the hold, and then we first prepare the provisional restorations, and we're executing the immediate loading protocol, as well as we have to select the proper transmucosal button. So first, let's start with the first category of the scan, the intraoral scan. Currently, I think the majority of the literature that we all agree and it supports that the accuracy of the cross-tooth intraoral scan, meaning it's the shortest span for the dentition, that accuracy revealed no statistical significant differences compared to the conventional impression. However, the cross-arch intraoral scan and edentalism, the discrepancy can be appreciated still. And of course, the result varies from different images acquisition, the scan strategy, as well as the scan surface morphology. However, the scan diagnostic purpose and also the provisional fabrication, I guess it's just no doubt that it's a key benefit for the treatment category of the intraoral scan. Also, with the improvement of the hardware of the scanner, and also it's for the software, how it's stitching and recombination of all this file of the images or the recordings, the scanning accuracy might improve. So if any of the doctors need any references, I would love to provide you. Just email me later on. So with the scan, you can see over here that you can actually be really creative, substituting between the analog workflow and the digital workflow. Here, I use the conventional workflow to fabricate the rim that you see over here. I establish all the landmarks that properly, and then I scan it later on for the future reference of the diagnostic wax-up. So the next step will be the virtual diagnostic wax-up. And this part is actually, in the real world, you just need to determine where the ideal teeth position is. This step is probably the most important part of the full arch full mouth rehabilitation. I guess we all agree with that, since all the landmarks in filling dentition is missing and all the teeth are flying here and there. We don't know where the future teeth are going to be. So I like to joke around with a lot of people that importance of the step, it's just like making the right decision for your life. Once the future goal is really clear and correct, the rest of the procedure is following automatically. You will really understand how crucial, particularly in our workflow, that this step how this step is going to be, because this virtual wax-up is actually where everything that gets started, and then it following through where everything gets ended. So let's take a look at the virtual diagnostic wax-up, how we actually exercise it out. Due to the time frame, I really couldn't address much about how we properly reestablish the teeth position. You just need to determine there are a couple of principles that you need to follow. The ideal incisor edge position, the plan of occlusion, and then you wax up the teeth by proportion, just the same as the analog base. And then you want to reestablish the lip support, the vertical dimension, and center relation, and so on. Now there are many softwares that you can see over here that utilize by superimpositioning the facial profile to your teeth, that you can actually directly visualize how the teeth alternation can affect on the profile, and you get the sense also roughly presenting to the patient how the future teeth is going to look like. So you can see over here the changes here along the photos, that you see how the template of the teeth that will be directly linked to our virtual wax-up in the design. So through the planning, you will be able to monitor the teeth position along with the profile, that you have like the real control of the cases for aesthetics as well as the function. And that's the best aid I consider comparing from the analog workflow. Here is the video examples that Dr. Chiu will play for me. You can see how we design it throughout the face. Sometimes you can utilize previous prosthesis or the wax stream I just show you guys, and then you reestablish the ideal teeth position. So once the ideal teeth position is determined, then the design STL file will be then transferred to Navident planning software, superimpositioning with the Combing CT. That the file Dr. Chiu will talk about it through some of the examples of video in the future, later on. So as I addressed previously, the accuracy of image superposition, that's very crucial. That's a key, and the precision, that's the key for achieving the precision of the planning. since we are dealing with millimeters or couple degree of the accuracy in the entire whole treatment. So there are some guidelines our team are experimenting it out, and now I would like to share with you guys since we're under the prep of the publications. Number one, for these couple in order to meet the standard for image precision, we need solid tooth landmarks and nice arch spread for image precision. That being said, we try to maintain the future extraction teeth best with minimal mobility for this purpose. And the teeth should have some characters with no scatters. And of course, you don't want it to be the future implant site because you need to extract it out and you cannot stabilize it. And with the proper distribution as ideal, you can, when you superimpose the image, you will understand the plan of the whole spatial world that's gonna be more accurate. In a case scenario that you don't have the solid tooth landmarks, then we would encourage you to either place a couple mini screws. For instance, 4 mini screws have proper distribution, or you can use some tissue landmarks. So this is how we plan on in the software, utilizing the pre-scan, the intraoral scan file, and the cone beam CT. Through the Navident software, now we could be able to really planning on the implant position, angulation depth, coming out through achieving the screw retain implant prosthesis. You can see in this case, we maintain some solid tooth landmarks, meaning solid. When we talk about solid, we actually need to sacrifice in the future for prosthetic convenience. In the case that patient literally has nothing, this is what I mentioned about the tissue landmark, the tissue markers that we use. We use the tissue, we use 2 millimeters of the zirconia balls attaching on the soft tissue as well as the template, having the patient have intraoral scan and the CT scan. So with that, you could be able to use the landmarks, the markers to superimpose both images to proceed on the treatment plan that Dr. Chiu is going to talk about that right now. So now, I will pass it to Dr. Chiu.
Okay, hi everyone. Can you all hear me? Okay, cool. So I'm Dr. Chiu. Hi everyone. So I'll continue my presentation from the surgical part of the digital treatment planning and also how I execute our treatment plan with the help of Navident. So from the day one that Dr. Kuo and I entered the program at Columbia, we was always educated to deliver a prosthetic-driven surgical plan, and also like everything needs to be planned out well instead of doing the bone-driven plan, the bone-driven surgical plan. Why? Because it's always like for the implant, we can always place it very straight, and maybe we can place 8 implants in 1 hour, like boom, 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 everything just shut in. But this is not what the patient wants. Although we feel very like pleased to see the X-rays like this, but this is actually what the patient wants. They want the teeth. They don't want the implant. They are willing to go through like all the procedures, suffer from the pain, the swelling, the bruise, everything, just because they want the fixed teeth. It's not because they want the implant. Implant is just a way for them to get the teeth. So always go for the prosthetic-driven surgical plan. That's what we've been educated under Dr. Tarnow's team. So how do we do that? Conventionally, I'm sure that everybody is familiar with the conventional flow of execute like a prosthetic-driven surgical phase. So firstly, you will have a radiographic template from your prosthodontist. And so they will have markers or use the barium solution to dip it in, and so that when the patient wear the radiographic template to check the cone beam CT, you will be able to see all the prosthetic design from your cone beam CT. And then you do the treatment plan based on the cone beam CT that you took. And then convert it to the surgical template Either you convert it from your radiographic template, or you do another one. You can do like a computer-aided manufacturing to have like a more accurate surgical template. And then based on that, you do the guided surgery. So it could be like partially guided or fully guided. From the conventional flow that I just introduced, you can appreciate there will be multiple lab works involved in the procedure. But for the digital workflow, it's gonna be so much easier than doing it in the conventional way in terms of the lab part. So to do it digitally, first of all, just as Dr. Kuo mentioned before, you need to have either several stable anatomical landmark, which is usually the teeth, or you can place several mini screws or mini implants if you don't have stable teeth, or just a customized stent with fiducial markers like the one that Dr. Kuo just showed. So this is the first step, and then you're good to send the patient to take the CBCT. And once you have the cone beam CT taken, just superimpose the image with the digital diagnostic workup you have. And so the image will show quite clearly on the screen, which is the one from the Navident system. We do finalize treatment plan with Navident. And then, so I'll export the treatment plan that we have to Dr. Kuo, and once she approves the treatment plan, we will use either stereolithographic guide or dynamic navigation to execute a fully guided surgery. So from the digital workflow, you can say there's almost no lab works if you go with dynamic navigation. And I know it's probably a little bit confused for those who haven't tried the dynamic navigation before. So this is the diagram that shows what's required to do this kind of treatment. The first one on the right side, that's the real patient. If you're sure that they have either a stable landmark, it needs to be like tripod, or it needs to be evenly distributed, not clustered on one side, or so that when you're doing the tracing part, it will be a lot easier for the computer to recognize your patient. And then once you have the scan, you superimpose with the digital diagnostic workup as that was shown on the top right of your screen. And then based on that, you finalize your treatment plan. On the day of the surgery, the patient will need to have the tracers secured on their either the head or the jaw, and also the tracers are the instruments that you are going to use. And then, so it's called the mapping part. Once the computer recognizes your patient and everything, you can go ahead and do the surgery based on the navigation part of the computer. So to make it more clearly, let's have a look take a look about how we execute that on the real patient. So this is the patient who we have, sorry. Okay, so from this video, you can appreciate there's a cone beam CT that the patient just took, and the bottom one, that's the digital diagnostic workup that was performed by Dr. Kuo. And we can simply superimpose these two images. Dr. Kuo and I will usually keep several stable teeth, not to extract them before the surgical procedure, just for the superimposing purpose. And so from here, after you superimpose, you can appreciate how easy it is to do the superimposition part. You simply click on the same point on the STL file and the cone beam CT. After that, you do the check on every sectional view, just like the one that I'm pointed. So make sure the outline of your STL file, this is the one from your original teeth, and it's coincide with the CBCT, the image. So to make sure that you're accurate, once you're done with this part, so for example, this patient, we're going to do the mandibular arch, and then the next step, we will mark the inferior alveolar nerve, so that make sure you're not touching it at all. mark it on the both sides. And then we will do the treatment planning. So in the treatment planning part, you place the implants. So it's very easy. You can appreciate that you can see there's a mesial, distal, buccolingual, and also the angulation of the implant. And plus, you have the superimposition of the STL file form so that you know where the future teeth are going to be. So you can adjust the implant position based on your future teeth position. Make sure all your implants are coming out from where you design it to be. And to move the implant freely. So this is a truly advantage of going digital. And from here, we do zero lab work. So I mean, we did a lot of work beforehand, but to transform the radiographic template all the way to the surgical template, we don't need to do any lab work. So now we're going to talk about, in terms of the implant treatment planning, how do we decide, like how many implants are we going to place, the implant site selection, and also the implant position, angulation, and the implant system that we're going to use. For the implant numbers, how many implants do we need in these kind of treatment to do the full mouth reconstruction for the patient with failing dentition? So from the literature review, maxilla and mandible are somewhat different. From the Perio 2000 that was published in 2014 by De Bruyn, you can appreciate from the second column from the left, that's the number of implants that was placed in different studies. And the one that I marked, that's the mean implant number. I do a bit of math. To divide the implant to the number of the patients. So that's the average number of each study. And from here, you can appreciate that for the maxilla, if you have less than 6 implants that was placed for this kind of prosthesis, the implant loss percentage is a lot higher compared to that for the patients who received more than 6 implants. And also from another systematic review study, you can appreciate that from the number of the implants per patient with over 6 implants, like more or equal to the 6 implants, the long-term survival rate is significantly higher than the patient who received less than 6 implants. And also from this study, it also mentions the implant distribution is somewhat important. For the patient who only have implants anterior to the first bicuspid, the long-term survival rate is much lower compared to the one with ideal anterior-posterior distribution. So this is the conclusion of the study. Implant number and anterior-posterior distribution along the edentulous maxilla seems to affect the survival rate of the prosthesis, and which is like the key point for the patient. So for us, how many implants are needed in the maxilla? Usually we will place 6 to 8 implants. And for the mandible, it's different from that in the maxilla. So this is the same study from De Bruyn, and also the second column from the left that shows the implant number that each patient has. And also we do a little bit of math calculation so you can appreciate the mean implant number. And looking from the third column from the right, you can appreciate the implant loss rate is so much higher for the patient who has only 3 implants or less. Also from the other study, this is also another systematic review. And if you have a look at the second row, which I have the one shows in the red, it says for the fixed restoration, if you have only 4 implants compared to the patient who has more than 5 implants or equal to 5 implants, the long-term success rate is so much higher in the patient who have more than 5. So for there's For the number, I know there is a bit controversial in between the studies, but for the most of the study, it shows that 4 to 6 implants are needed in the mandible to maintain the long-term survival rate for the prosthesis. So that's the implant number, and then we're going forward to the implant site selection. For the implant site selection, it's also different in the maxilla and the mandible. For the maxillary arch, we will divide it into Zone 1, Zone 2, and Zone 3, according to Bedroson's study in 2008. So for the patient who have sufficient bone in all these 3 zones, we will place 6 to 8 implants evenly distributed. And for the patient who doesn't have enough bone in the Zone 3, that's usually for the patient who has their teeth pulled out in the fairly like for a fairly long time, and then they have an pneumatized sinus. So if they don't have like bone at the sinus area, then we will place 6 implants. Anteriorly, we will place it in the axial way, and the posterior one will be tilted as the one that was shown in the diagram on the right. And for the patient who doesn't have like sufficient bone in like all 3 zones, for this kind of patient, I know that some doctors will place zygomatic implants or the implants around the pterygoid bone area. But for me, I got the training as a periodontist, so I don't feel comfortable placing those implants. And usually we prefer to have straight implants. So we will do it in the stage approach. We'll do the sinus augmentation or the guided bone regeneration prior to the implant surgery, and then we will still place 6 to 8 implants to complete the whole treatment. And for the mandibular arch, the key is the nerve, where the nerve is. For this kind of treatment in the mandibular arch, if the patient has sufficient bone, then we will place 6 implants or more. And they're usually axial and evenly distributed. For the patient who doesn't have sufficient bone in the posterior area, but still have a bit, then we will either place 2 or 3 in the anterior, like axial implants, and posteriorly 2 tilted implants, a bit similar to 014 concept. Or we will place 4 implants axially in the anterior area and 2 short implants in the posterior area. For the patient who has severely atrophic ridge, we will place 4 implants anteriorly to the mental foramen. So that's the implant site selection. Then we will move forward to the implant position, angulation, and the implant system. These are the very important factors you have to always discuss about beforehand with your prosthodontist, because these are very, very crucial for the prosthesis design and the connecting part. So for the implant position, we would like to have this implant access hole coming out from either the occlusal surface, the cingulum, or slightly towards palatal or lingual, but not affecting phonetics and tongue space. Why is this so important? Because for every implant brand that you're going to select, they all have different features. Like for instance, for a certain brand that I use it as an example here, they have only multi-unit abutment in 30 degree and 17 degree and in a certain diameter of the implant. So if you place, like to say, if you place a narrow diameter implant in the anterior and you request your prosthodontist to correct it to like 30 degree, and you use the tri-channel implant, then it's like you cannot restore the implant because they don't have the component to do it. So these are the reasons why you have to always make sure you talk to your prosthodontist before you decide the implant system that you are going to use. For the angle correction, because bone are not always at where we want it to be. Like in this case, the crown that you can appreciate from the arrow, that one is actually quite far from the future teeth that we have planned, like the outline I'm drawing right now. And so for this part, you always want the access hole to coming out from the cingulum like here. So I'll talk to Dr. Kuo and telling her that according to the bone in this particular area, we will need to do the angle correction. So I want it to be corrected with a 17-degree multi-unit abutment, and then once we both agree with this, I'll do the treatment plan based on the what the image shows. So once we're all on the same page, I'll go forward to the surgical treatment. So like this. And this is just a diagram to show that we're going to move from this step, the treatment planning part, to the actual surgery executing part. You have the patient with a like stable head tracker or jaw tracker and all the mount on the instrument that you need. And then we do the tracing part. The tracing part will be you have those points on the stable teeth, and then you do the tracing on the patient for all these teeth as that is shown on the screen right now. So once this part is done, we will do another work which is called accuracy check. So you will have this point, the blue like small balls, you will point it at the like a specific side of a tooth. For this one, that's tooth number 22. And then you make sure it coincides with the point that you are pointed in the patient's mouth. So once it's all set, then we will do the surgical part. The surgical part, there will be the one on the bottom left indicating the angulation of your drill and the depth of your drill. And then that's the buccolingual and the mesial-distal of the drill. So you can do the surgery under navigation. This is usually what it's going to show on the screen. So you follow the screen. I know it's there's a learning curve because we usually see the patient while we are doing the surgery. But when you're doing the navigation, you look at the screen and you have your assistant to look intraorally to take care of the patient. The beauty of using the navigation is that the flexibility during the treatment. So for instance, this patient with the implant number 6 and implant number 8, once I flip it out, I found out that the bone doesn't heal as that was shown on the cone beam CT. So I talked to Dr. Kuo and tell her that we will need to modify our treatment plan. I don't think I can have both implants locked in tight. So I switched the treatment plan during the surgery, and then I'll tell Dr. Kuo where I'm going to switch my implants, so she can convert the prosthesis to how I'm gonna alter the implant position. So she can have the prosthesis ready while I'm doing the surgery. And then once it's done, we're going to talk about the loading protocol. For the loading protocol, there will be 2 key factors to decide whether we can load the implant or not. Firstly, it's about the primary stability. We feel comfortable to have our implant loaded if they have stability, the insertion torque equal or over 35 Newton. And we need to have cross-arch stabilization to execute this kind of treatment. So make sure you always have implants on both sides. And after the treatment, I'll place the healing abutment on top of the implant that doesn't lock over 35 so that there will be no confusion. And then this is the beauty of the treatment after the treatment procedure, as that you can appreciate from the photo. The implant screw access hole all come out from the very ideal position, and then I'll hand over the treatment continued by the Dr. Kuo.
So I think we're a little bit running out of time, so I'm going to only talk about a couple key factors remaining, how we accurately superimpose the image to plan out and fabricate the provisional restorations to assist us on the immediate loading protocol. Chiu, can you advance for me? I couldn't advance right now. So this is how the image that we will superimpose from the Navident STL to the pre-diagnostic wax of the implant. Next one, just keep on clicking. So as you can see from the left, we have the Navident plan. That's the STL file. You can see the teeth along with the implant position. We use the 3Shape software, and then we superimpose again back to our pre-designed diagnostic wax up. So the wax up that you can see from the bar that's on the top, the blue bar indicating where the corresponding implant position. Next. So you can see over here right now, each of the angulation can be examined there. Next one. And here is the video, but I guess we're running out of time. We'll just skip it. So you can see how we flipped it, and then we can be able to check along all this screw access hole that we are going to spare in the future for the immediate loading protocol. And the next one will be the fabrication of the prosthesis. For now, from transferring from our design, the material and the fabrication procedure that we feel very comfortable with, that is the milled one. Next slide. So we use the milled provisional. There's a whole lot of discussion about the 3D printing material and the milled one. For now, the flexure strength, in order to meet the flexure strength for immediate loading protocol, that this provisional will need to last intraorally in the patient's mouth for more than 6 months. We still feel more comfortable with utilizing the milled one. Next. And the last part I would like to introduce, guys, is the part that Dr. Chiu has been addressed. That's the selection of the multi-unit abutment and what's the importance of it. So you can see over here, as she talked about that a little bit, if you follow the wrong teeth position that you did not see through that clearly, you might, at the end, running into the problem that you have no running room to restore it at the end. So always need to plan your implant following your ideal teeth position. The second part will be the disparity between the implant and also the teeth position. You need a multi-unit abutment to correct the angulation, as well as it helps you to bring up the abutment implant level to the tissue, more close to the free tissue junction. Next one. So it's very important to understand your implant system because it only comes with a certain degree and certain color height of the abutment that you can utilize. So then you, for the next one. Yeah. So you can see the patient over here to wrap it up, that this patient we also executed through the digital workflow, that we also have the teeth planned out, we have the provisional prepare, and then we're executing the surgical procedure utilizing the Navident dynamic navigation system, and I select the proper multi-unit abutment, connected it, and then executing the immediate loading protocol. You can see the implant in the middle, at the right over here, at the left of the patient's quadrant, that we changed the plan during the treatment, but we then still be able to finish and executing out the procedures with no problem. So as the last, you can see this is the before and after photos that the patient lost the vertical dimension previously, and with the same day of the immediate loading protocol that we restore the patient's vertical dimension, and he was pretty pleasing with the result. So the last part of once you get through the healing phase, the last part of the definitive prosthesis, you just drop it in with ease, with no surprise, under this control of the procedures. So you can see the patient over here, this is Mr. Kato, that before he just almost gave up his life. He was telling me, say, just, give me some teeth that I just want to be able to chew. I don't care about how I look like. After I provide him the full arch implant prosthesis, you can see how dramatic he changed even through his appearances. He was telling me that nowadays, instead of going to barber shop, he always go to salon, and he really cares about his life right now, feel motivated. And this is the part me and Dr. Chiu were really focusing on. We feel like throughout the control procedures, you're not only giving back them their teeth, but you actually change totally of their life. And we don't have any single day that we don't feel proud of as being a doctor because of these type of procedures that's been done. That being said, thank you very much for your participation. Sorry that we're running behind of the schedule, and we would like to take some questions.
Okay.
Are you fixating in the lower arch? How are you fixating the jaw tag? Are you basically cutting a groove in one of the teeth and bonding the jaw tag in? Because you're taking out all those lower teeth. So how are you attaching the jaw tag to that throughout the procedure?
Okay, so I'll answer that question. For the case that I did, I have my jaw tracker on tooth number 27. That's the one that we didn't pull out from the very beginning. And I used tooth number 26, 28, and also teeth on the bottom left to do the tracing part. So these are the teeth that are not in my future implant position. I have these teeth traced first and then place all the implants except the one on tooth number 27. So after everything's done, so I have 6 implants in patient right now. I use the future prosthesis as an indication to place my last implant. This is because this patient, he travels very far and I don't have a chance to place 4 screws before the surgical part is executed. So that's usually what we do. We will keep the teeth as long as possible until we place most of the implants. And if there's only 1 implant left, then we will do it in like a conventional way.
Great. One of the questions is, how do you overcome the scatter with the dual scanning and lots of metal with crown bridge?
So, right.
Unfortunately, that's a real problem. How do you guys do it?
So I saw the bottom, that's from Mark Park, the question. So for the scatter, we don't actually use the dual scan. So instead of dual scan, you scan your template, we actually do the intraoral scan. And then we have the same landmarks that we do the CT scan. So we superimpose this combing CT image with the intraoral scan. And here we need to have the solid landmarks. But talking back about the scatter of the alloy, we literally cannot overcome it. And that's also one of the projects that we're working on right now, because regardless of any type of alloy, even zirconia or gallapurgia, you have some type of scatters you can appreciate on combing CT. So how to select the material for the fiducial markers that's transferring and also superimpositioning accurately for both image, that's what we've been experimenting on. You can see the previous view that we use zirconia tissue ball. You can encounter with some scatter as well. For that, we increase the numbers and the distribution of the markers. So with each of the markers, you might have some discrepancy, but then along with all 8 or 10 markers, you might achieve more accuracy as a total. So you can superimpose both image more in spatial accurate way to achieve the precision.
And then I think Selene can answer that Mark Park's question. Sorry, not Mark Park. Dao Pump, the consultation part, the digital workflow, the timetable for the consultation to complete.
Okay. So typically, the first time when the patient comes here, we will talk about how the potential future plan for your case. That would be like 30 minutes of the raw consultation. If the patient is interested in, then we will schedule patient to have 1 or 2 times of the data, digital data collection. Once we have that, then I need to do a lot of work, actually not at the clinic, but behind the scene. I plan all the software and then have all the images superimposed. Plus, I need to discuss with Dr. Chiu about the surgical plan. So if you can finish that at home in a properly timed manner, then you can facilitate all this workflow. So I think that's also the beauty and definitely the benefit from the digital assist, because you can literally work a lot not having the patient next to you. But then that's also the downside. You need to work a lot at home extra.
Okay, also there's...
I saw that, let me ask you guys this. I saw, obviously with the maxilla case that you showed, the head tracker, obviously important to serve as a reference there. But when you have a single or maybe multiple teeth that you're doing in the maxilla, do you tend to use the head tracker more often, or do you tend to fixate the jaw tag to the teeth?
Yeah, for the maxilla, I prefer to use the head tracker because sometimes after we take out all the teeth and the head tracker can still be there. So if the machine is still accurate, then even after you pulled out all the teeth, you can still do the surgery under the navigation. And even in some cases, like extreme cases, we do the bone tracing. If you have a stable head tracker and there are some little spikes on your bone, then you can also do the tracing on your bone. And I've tried that once before, and it's actually quite accurate. So for the last few implants, I can do it in that way. So that's the reason why I prefer the head tracker. And now they have like the newer release of the head tracker. That's actually a lot more stable compared to the first generation of head tracker.
What about like a single tooth, like number 8 or number 9?
Oh, then
and all the teeth is present.
Then
you still use the head tracker, or do you prefer to bot?
No, then jaw tracker is a lot easier to use, and it's more stable. You don't have to worry about touching the patient's head or like when they're moving or so, because it's closer to the like if you have it on the stable teeth, then it's not gonna move anyway. Yeah.
So our friend from New York, Elena, she is wondering how much time it actually takes for the entire whole surgical and immediate loading protocol would take. So I would tell you, for the first 2 cases that we did, it took probably triple times as compared to the conventional way that we did. So there's definitely, as Dr. Chiu mentioned about, there's a learning curve on that. So getting familiar with the software and not really certain about how accurately to superimpose the image. At the beginning, we encounter a lot of discrepancy and difficulty. So that's how we sat down and we discussed all the time. And so far we've done how many arches? 10 arches or 12? We've done like as we proceed more, definitely the time gets shorter. And we could be able to really, enjoy doing it and laughing on that, chatting a lot, instead of, just being very intense and worrying about something might go wrong. So typically for now, the time that's required, that would be surgical part, that would be probably, I would say 3 hours. And yeah, because there's a lot of setting up for the equipment prior to the actual, placing implants that we need to calibrate it. And afterwards, the immediate loading protocol, I would say like 2 hours, we can finish that with the pre-planning and predetermining drilling holes. So as long as you really get familiar with setting everything up and having the equipment and the software, working out, that it literally wouldn't, drag too much time for the actual treatment. But you have to really certainly pass through that learning curve.
I think it's really great how you guys merged the digital smile design, 3D digital workflow, immediate loading, the CAD/CAM pieces. I think it was great. I just want to congratulate you both on a wonderful, wonderful teamwork and just a wonderful case in changing that man's life. It's really great.
Thank you, Dr. Mandelaris.
Okay, Beth, I guess we do have, I don't know if Beth, if you're there, I don't know if we can hear you, but there are a couple of courses that are going to be coming up. My partner and Dr. Sylvia LaRosa, fantastic periodontist in Washington State, going to be getting a hands-on workshop at the AAT meeting in Chicago this November. There's a course that's going to be coming up at the Alabama Implant Education Center in October, and then my partner and I, Dr. Groot, are having an in-house course on December 5th, a live hands-on training for those of you that might be interested. Again, it's in Chicago. So if this is exciting to you and would like to kind of learn more and have some over-the-shoulder, more in-depth discussion on this technique and get more familiar and jump in, these are 3 great opportunities to get involved. And the email is there at commissioneclarolab.com. Get registered, get more information. Certainly, I'm available if anybody has any other questions or wants to talk with me personally about my experience with the technology.
Thank you, George. Thank you, doctors. I just want to add to what George just said about the upcoming courses. The opportunity at the AAP will be a hands-on opportunity with, as George said, himself, Sylvia LaRosa, and Bradley DeGroot. There are 2 sessions, and you can register on the AAP website. The course that we have coming up at the Alabama Implant Educators Facility in Bessemer, Alabama, this is a live surgical opportunity. There'll be 1 day of didactic, hands-on software training, and then the second day, attendees will have an opportunity to practice on live patients. All the patients and all the supplies are included. So to get more information or register, the email is there. And then as George mentioned, the over-the-shoulder course is a fabulous opportunity to go into George's amazing operatory and observe him, a master clinical trainer, doing 2 to 3 live cases. And obviously space is going to be limited for that. And then as always, we have our hands-on opportunities at our facility in Toronto, and those take place the 2nd Saturday of every month, starting up again in September. So with that said, I'll turn it over to ViewMedi, and they can walk you through how to get your CE. This program was recorded, and you can check on the ViewMedi website or on the Navident website probably in about a week or so. So again, thank you very much. If you have any questions about upcoming education or learning opportunities, feel free to contact me at my email. Have a great night. Doctors, thank you so much. It was such a really amazing presentation.